I would just say to you that the social responsibility for us as healthcare providers is paramount. And I think that we serve as examples and we're leaders in the community. And most of your family members will come to you with questions and issues related to this. And I think despite what you hear on the news and how people are behaving, that we have COVID fatigue, these are still the most important things. Just one slide about just to let everyone know when people say, "Well, I'm at high risk. I'm a high risk group." What is the high risk group for patients to get very ill from COVID? And they're pretty clear now that these are the illnesses that put you at increased risk, or conditions that put you at increased risk for getting COVID-related mortality and very ill. So old people over the age of 65, residents in nursing home and long-term care facilities, patients with organ transplants and other immune deficiencies, including use of systemic corticosteroids or immunosuppressant therapy. So, for example, someone who is on immunosuppressive therapy for rheumatologic disorder, or someone who has HIV and is on immunosuppressive therapy, these are people that are at increased risk for getting very ill. Chronic lung disease, we hear a lot about asthma. It's really the moderate to severe asthma patient, not the person who uses a PRN inhaler. Patients with cystic fibrosis or chronic lung disease like pulmonary fibrosis. Cardiac disease. So when we talk about cardiac disease, we're talking about people that have coronary disease, particularly people who have had MIs, ischemic cardiomyopathies. These are the people at increased risk. There's some evidence that in patients that have COVID, there's an increased thrombogenic risk, so increased risk potentially of MIs, although we haven't seen much of that. We've seen an increased risk of stroke, usually in patients after they recover, and that's gotten a lot of press. Cancer patients, hypertension, obesity seems to be a big issue in patients that end up on ventilators and have major ventilatory issues. So BMI greater than 30. Diabetics, kidney disease, liver disease, patients with prior stroke and cerebrovascular disease, patients with dementia, smokers, and also other patients with hematologic disorders, and certainly your pregnant person. Very important to avoid exposure to patients that are pregnant. This is those of you who've heard me speak before, I try to use these things to make you laugh. And I like to look at the audience to see if you're actually laughing. But, this is it's Halloween season. So, despite all the social distancing, we've seen a bunch of this in the hospital. This says, looks like he's going to pull through, but it must have been a vicious attack. He's lost a lot of candy. So with a bag of, if you see the IV bag, it says Tootsie Rolls on it. So I thought this was funny. So social distancing important, but Halloween's coming up, and I would ask everyone to, be smart and about their exposures. Everything's changed for all of us in this room and outside this room, and remote conferences as an example of good and bad. I'm a big in-person kind of person, kind of guy, but the reality is that there is clear benefit to remote conferences. What we've seen, not only locally in our health system, but everywhere outside, is that healthcare professionals are participating more in conferences than they ever have before. As an example, we have several conferences in the Heart Institute, and we've seen a remarkable increase in people logging on. It allows you to log on from the car, from home, from any location, put it on mute and listen, even exercise. So I think, although it lacks intimacy, it certainly gives you increased access. Remote learning obviously for family members and for us. What else has changed? Well, obviously we've had more direct family contact, but less overall contact. I like to say that you're exposed to the same people. They say this is the best holiday. This was the best illness for dogs because dogs had you home all the time. So dogs love when everyone's around, but overall we've had less contact with people. So I'm going to review some data of things that were published in 2020 around the cardiovascular world, and give you a sense of some of the new data and how it's going to affect how we care for patients. I just want to keep in mind that we've seen a lot of publications in 2020, but I expect that 2021 and 2022 is going to see a marked reduction in research. Why is that? Well, I think it's for a bunch of reasons. I think much of clinical research is randomizing patients to trials. Hasn't been a great time to randomize patients. We lost 3 months of solid patients coming into the hospital other than for emergent issues. I also think that we've seen a downturn in patients being interested in randomized trials. I also think that there's going to be delays from the pharma companies because many of them have been offline. So I think that 2021 and 2022 is going to see a drop in clinical research. One thing I wanted to talk about was telemedicine, and I think that telemedicine has seen a dramatic improvement in access. Again, a positive that came out of COVID. Is it the same as in-person visits? No, it's certainly not. If you can't read the slide, it says offhand, I'd say you're suffering from an arrow through your head. But just to play it safe, I'm going to order a bunch of tests. It's a really good doctor there. But the reality is that when we see patients with telemedicine, it has served a major positive overall, in my opinion. And as this technology has become available through our improved ability to log on, whether it is through the EMR or whether it's through FaceTime, or because there was an exemption for HIPAA using FaceTime this year as well, or at Cooper we used a couple different systems. Its definition is use of medical information exchange from one site to another via electronic communication to improve patients' health care during a remote clinical service. It's clearly saves money, decreased travel time. It's more efficient in terms of everyone's time, and I think it's served in many fields very well. Before the visit, though, it would require a lot of technology preparation, as in this meeting. We were delayed by 15 minutes because we had an issue. So we're seeing that in our patients, particularly the senior patients who are not used to using technology. But once they get on, they actually like it. The limitation really is clearly physical exam. It's getting better with newer technology. There's technology where patients get a packet delivered to their home that literally will have remote blood pressure, remote weight. You can actually look in someone's throat with a disposable light that comes at the end of a monitor. There's tremendous growth in that technology. I think over the next 6 months to a year, we'll see more and more of this. The internet and the Wi-Fi everywhere, ubiquitous Wi-Fi in people's homes, have really improved access. I mean, can you imagine if this pandemic occurred 10, 15 years ago? None of this would be technologically feasible. And the most important thing is that there was a Medicare waiver, and that waiver continues. So they're willing to pay for reimbursement. And all the insurance companies have also extended that waiver. And that waiver continues. Now, time will tell whether that waiver will continue long term. I believe that it will. The reimbursement for these visits is limited. It's not, you can't bill, you can bill as an example as a level 3 follow-up or a new patient. You can't bill for, you won't get paid for higher reimbursement from Medicare. So, but it's still great. We have docs that have embraced it, and we have docs that have not. We're back to pretty much full visits. I was in the office yesterday, and I'll be back in the office this morning. For the first time the last 2 weeks, I had 0 virtual visits. Everyone came in and everyone showed up. So, but we are reserving it. As an example, I'll use it for someone who's just discharged from the hospital. I see they're trying to get him on my schedule. I'll say, why don't we do a virtual visit next week, and then you'll come in 4 weeks. So I think there's some opportunities to use it long term for reducing patients having to really push the limit of getting out of their home in the first week or two. So let's go over some new data. I won't go too long because I know we have a big agenda. I'm sorry we got a late start, but I just want to review a few um, studies that were released this year that affect pretty much most people in this room, everyone in this room, just to give you a sense of what's out there. We had talked a couple of years ago at this meeting about subcutaneous defibrillators. Subcutaneous defibrillators are defibrillators that get put in the axilla with a tunneled lead. Someone's texting me. I hope it's not okay. Okay, you can go a little longer. Okay. All right, so we're good. So bottom line is that subcutaneous defibrillators go in the axilla and they go under the skin, and the leads sit subcutaneously. And so the lead is sitting under the skin over the heart, and a vector is created to the axillary, interaxillary line. And so if a patient has a VT or VF arrest and they have a reduced ejection fraction, which is their indication for a defibrillator, they get shocked. And what we found is there's a study that was done, a large study, randomized trial that was done and followed these patients for several years, showed that clearly there were less complications with a subcutaneous defibrillator. Less complications would be less pocket infections, less pacemaker lead infections, but patients had more inappropriate shocks. So inappropriate shocks would mean it's hard to program these devices, so patients get shocked potentially for artifact or for atrial fibrillation as opposed to ventricular tachycardia. So, but overall, it's safe. Technology will continue to improve. Wearable heart monitors, tremendous amount of data on Apple Watch and similar type of monitors to look for arrhythmia detection and now even QT assessment. So for atrial fibrillation, large AFib trials using Apple Watch show that detection of atrial fibrillation is really effective in patients that are wearable heart monitors. We were actually principal investigators through Andrew Russo with one of those trials, and so we were happy to be part of that. QTC assessment, if you remember, QT interval is usually measured in multiple leads. When you have an Apple Watch, you're usually only getting one lead or two leads. Technology is getting better where you're getting more data, but there's a couple apps out there where you can actually put the watch on your lower extremity, another lower extremity, then your wrist, and get multiple leads. So QT assessment important in patients that are on medications that increase their risk for ventricular arrhythmias. So this is remarkable. What we saw is a profound decline in the acute MI rates during COVID-19. And all of us experienced that, particularly the medics and the nurses in the room. During those 3 months, it was kind of a strange absence of acute MIs. Now, we really didn't know why. Was it because there were less MIs? People were home. They weren't doing stressful activity. Was it related to the fact that they were having MIs at home and they would just ride through the MIs? Was it that they ignored symptoms? Was it they were afraid to come to the hospital during the pandemic? Probably all of that. It's probably all of that. Immediately after the walls went down and we started seeing patients, we did see in the first month or so, like in June, saw a large number of very sick patients. And those very sick patients appeared to have had an MI during COVID, and now we're coming in with heart failure and reduced ejection fraction. Also, it's hard to know how many patients died at home during the pandemic, not related to COVID, but actually from coronary disease or an acute event, and they just didn't make it to the hospital. Very important, this has been widely published across the country, is that ED visits have declined dramatically, and have not seen them recover. Meaning, if we had say 100 ER visits and we were down to about 30, they're back up to around 70. But where we're at is that when the patients come to the ER, the admission to visit ratio is remarkably increased. So more patients are getting admitted that come to the ER, but overall less patients are coming to the ER. Had a conversation with our ED director that directs our ED residency. We have 17 residents that come out every year. And he said by now, normally they all have jobs. And frankly, none of them have jobs yet for July. So it tells you that EDs across the country and people hiring are nervous to hire because they were staffed to a certain level and now they're staffed to a lower level. I just want to mention a couple different medications that have gotten a fair amount of press. SGLT2 inhibitors, which are these medications. These are the brand names of these medications. You might see a lot of ads on television. They're sodium glucose co-transporters. And what they do is they were designed for patients with diabetes and now indicated for readmission for reduced risk for in patients that have heart failure to readmit them to the hospital and they actually feel better, less hospitalizations over a 90-day and then 1 year period. These medications, what they do is they increase urinary glucose extraction and also sodium. They reduce sodium and glucose reabsorption in the proximal tubules. So you really get a natriuresis out of your body, and so it decreases your plasma volume. When it decreases your plasma volume, it reduces your preload, so it reduces your filling pressures. So patients have lower preload, almost works as a diuretic, but more important than as a diuretic, it also appears to downregulate sympathetic activity. So what we know about patients that have heart failure, their sympathetic nervous system is amped up. If you measure norepinephrine and epinephrine levels in patients that have heart failure, they're way ramped up. So if you can reduce them, it's the body, it's a bad mechanism to compensate. And now you've downregulated that response and patients actually seem to do better. The problem with these medicines is that it's an additional medication on top of beta blockers, ACE inhibitors, sometimes Entresto, which are not without cost. So I think right now they're very expensive. They're about $5 a pill out of pocket. Insurance companies are increasingly receptive to approving these medications. Next one is a PCSK9 inhibitor, which I think you heard about it last year. We talked a little bit about these medications. What is a PCSK9 inhibitor? Well, PCSK9 is an enzyme that is involved in LDL receptor degradation. And so what happens is if you block the activity of PCSK9 with a monoclonal antibody like Praluent or Repatha, which are the two on the market, there are more to come, then you reduce the degradation of the LDL receptors and increase the clearance of LDL from the system. So LDL cholesterol goes down, and this is an alternative or potentially an additive to other medications like statins that we currently use. So it's a different mechanism of action. They're monoclonal antibodies. They're very expensive. They're injected. You inject them anywhere from every 2 weeks to every 4 weeks, depending on the dosing and the med. Because they're a monoclonal antibody, there's sometimes people get fevers related to it, but they're actually fairly well tolerated. We use them in patients typically who are not a target with statins. So we have a target of where we want their statin to be. I mean, their LDLs to be, or people who can't take statins. There's a lot of people out there, as you know, that can't take statins. But now studies are coming out that showing that post-acute coronary syndromes, patients post-MI, benefit from these drugs. And I think that over the next year or two, we're going to see that patient has an MI in the hospital. We're actually going to start them on a PCSK9 inhibitor in the hospital and continue it for 90 days, 120 days, maybe even 180 days. As you know, when we send people home post-MI, we often put them on a very high-dose statin for 6 months, because we know that helps reduce the incidence of events. So this may be even better. The data is dramatic when these patients get PSK9. The LDLs go down to remarkably lower levels. Some other studies that have been released this year is what we know is better blood pressure. But better blood pressure control is better overall. What is better blood pressure control? 135 over 85 and below. The lower you get someone's blood pressure, the lower the incidence of kidney complications, cerebrovascular complication, cardiac complication. So more and more data about better blood pressure control. We also know that this year there's a lot of data on more TAVR choices, newer valves. We just had a new valve, a third valve released, and broadening indication. A lot of data about using TAVR valves for transcutaneous aortic valve replacement as opposed to open surgery for patients that are low risk as opposed to medium or high risk. So that's one broadening indication. The second is we're seeing more and more patients with aortic insufficiency or bicuspid valve, not aortic insufficiency, but a bicuspid valve, correct me on that. But aortic insufficiency, not yet, but bicuspid valves that are primarily aortic stenosis, you're seeing more and more of these valves being used as opposed to surgery. There's a whole bunch of studies on using NOACs like Xarelto in patients that have peripheral vascular disease. So you add a low dose of Xarelto to these patients that have bad vascular disease, and it reduces their claudication and reduces the incidence of them needing intervention. So you may be seeing some of these people coming in on low dose Xarelto and they have normal renal function. They say, why is the Xarelto dose or other NOAC doses reduced? And it's not because of they're not being used for atrial fibrillation. It's being used for peripheral vascular disease. Big study was released on doxycycline. People thought that there was a potentially an inflammatory bacterial reason for AAA. Years ago, we did studies like this for coronary disease, and it was a negative study. Well, the vascular people did a big study on doxycycline, and it does not prevent AAA expansion. These patients were followed for up to 10 years.